Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Let's turn to the question of progression, and you want to start a new systemic therapy for a patient with an EGFR mutation who has been on EGFR inhibitors and is clearly progressing. Do you favor chemotherapy? Do you favor inclusion of immunotherapy? Where does immunotherapy fit into that mix in your mind, or do we have any sense of a standard here? Carolyn?
So in regards to the chemotherapy plus immunotherapy, I think in the EGFR patient population, the only results that we really have right now are from the clinical trial called Empower 150, thank you. And that was a combination of platinum doublet with atezolizumab with bevacizumab.
Tecentriq is atezolizumab.
Thank you.
Bevacizumab is
Avastin.
Right.
And in that study, they actually did include patients with EGFR alterations, and most of the other clinical trials with the combination of chemotherapy with immunotherapy excluded those patients. And so we can't really say with certainty that the results would be similar, but they did find in those patients with EGFR or ALK that there was a benefit in that patient population. And we have seen in our clinic that patients do respond to that combination, and so I often will go to that, or if they are not able to tolerate that specific regimen, then using the extrapolation of carboplatin, pemetrexed, pembrolizumab as well.
Okay, so just to translate, specifically the Empower 150 regimen was carbo and Taxol or paclitaxel as the chemo regimen, an older standard, has the problems of hair loss and potentially numbness, tingling in your fingers or toes called neuropathy, and the Avastin and Tecentriq, a 4-drug regimen, costly but does have some evidence to support it, just limited evidence in a world where that is the leading evidence. We have, in the land of the blind, the one-eyed man is king, and that's basically almost the only information we have, except, as you say, extrapolating of giving chemo and Keytruda in from a trial that didn't include patients with EGFR mutations. Heather, what's your view of the place for immunotherapy, or where you go after deciding that you need to move on from EGFR-based therapies?
Right. So we have a little bit more data than that. So there was one other trial that did include patients who had EGFR mutations. And I'm going to focus just on EGFR. I think in ALK, there's even less data that there's any activity of immune therapy, even though ALK patients often have high PD-L1. So, we're talking about EGFR and we'll talk about ALK later, but I'm just going to say that. I think for EGFR, I do believe there can be a role for immune therapy and that we can use PD-L1 in some cases to help, and that high PD-L1 EGFR, there is some single agent activity, maybe 10, 15%. I have a couple patients who've done very well with immune therapy, have EGFR mutation.
As the only therapy.
You're not a single agent, right? And I also have, but in the setting where there's low PD-L1 and EGFR, I'm much less enthusiastic to even try it. In the world of chemo plus immune therapy across the board, PD-L1 levels don't matter as much. So we don't know, does that matter in the setting of EGFR? But we don't know. We do have the Empower 150 data, as Caroline went through, the 4-drug regimen, definitely in the EGFR subset. And there was a small percentage of patients, but there was in that subset an overall survival benefit, which is definitely intriguing. But we can't forget about the fact that there was also the Empower 130 trial. And the Empower 130 trial also included EGFR patients.
I appreciate you bringing up, that's West and colleagues.
Yeah,
Lancet
exactly, right.
Oncology. Yeah.
And so that was carbo
Mhm.
with taxane, nab-paclitaxel,
Mhm.
with or without atezolizumab, the Tecentriq,
Mhm.
but without the
The-
bevacizumab,
Mhm.
right? And in that trial, the EGFR patients had no benefit
Mhm.
at all, right? So a chemo just plus or minus the immune therapy in that trial, no benefit. When you add the bevacizumab, benefit. And we know that the VEGF drugs like bevacizumab, Avastin definitely do play a role in the setting of EGFR. So is it about the 4-drug regimen, or is it about the chemo plus immune therapy? And I know a lot of people are giving carboplatin pemetrexed with pembrolizumab Keytruda because we like carboplatin pemetrexed because it's better tolerated.
Mhm.
And so we think it's going to work better and patients tolerate it. And so that's what we almost always give. And do we add that immune therapy to it or not? A lot of people are doing it, but we have zero data. So there are trials being developed looking at, well, maybe that 3-drug plus immune therapy is better, but we don't know. So there's a lot we don't know.
Mm-hmm.
But I actually, in my practice, I'm not giving immune therapy second line most of the time.
Mhm.
I'm giving chemo with Avastin most of the time. I'm using pemetrexed with Avastin most of the time. That's the Olympta chemo.
Mhm.
But I have given the 4-drug regimen to patients, often 4th line,
Wow.
right? And that's with the idea that we kind of move through everything that we know works. We're into what might work. Patient's still good shape. We'll try it. I've had some success with it. Is it based on any evidence? No. I mean, the trial included patients who had had TKI
I
in
think
the trial,
this is
right?
a situation where
Mhm.
there's so little evidence, you're forced to make choices
Mhm.
without much evidence. My concern, and yes, I'm aware of the trial without the Avastin, of course.
Since you published it,
yeah. but the problem is that is a very limited number of patients in that analysis. Even the Empower 150 is still a small number of patients. And so it's hard to know, and I'm not disagreeing as much as you just don't know how fine a point to put on this trial looked positive and this trial looked negative when you're talking about limited numbers and just
Right.
maybe the chance.
But you can't only look at the positive one.
No.
Right. You've got to look at the whole story.
Understood. And again, I think that does raise the question of whether the Avastin is a secret sauce. There is a trial being done from the makers of Keytruda, pembrolizumab, called Keynote 789 that is looking at chemo alone versus chemo plus Keytruda in EGFR mutation positive patients who had progressed on EGFR inhibitors. This, I think, will be very helpful. We need to ask these questions in a methodical way rather than just as a cobbled together afterthought from other trials, because I'm sure the people watching this video will feel like this is an important question and we're just gleaning what we can from the scraps we've got.
Right. And we're also doing a trial in collaboration with Fox Chase and some other institutions. That's the carbo pemetrexed, bevacizumab, Avastin, plus the atezolizumab Tecentriq, right? But it's not a big randomized study. It's a smaller study. So will we get a definite answer? We don't know.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, and Takeda. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.